Welcome Professor Dr. Hossam El Ashmawy, who is the Professor of Anesthesiology and Intensive Care at Cairo University, and he is also the Vice President of the Egyptian Society of Cardiothoracic Anesthesia, and he will talk to us about the current concepts of lung protection in cardiac surgery. Please.
Thank you very much, Mr. Chairman. Thank you, ladies and gentlemen, dear professors and colleagues. Thank you for staying this late after it must be very exhausting day. My talk will be about the current concepts of cardiac protection in cardiac surgery, of lung protection in cardiac surgery, and I wouldn't want you to be intimidated by cardiac surgery because this obviously is not a cardiac anesthesia conference, but the concepts, the basic concepts that apply are the same, almost the same as what you have heard in the previous lectures. We will just highlight some of the specific points characteristic to the cardiac surgical patient and see how the concepts of lung protection will apply to these patients. So to introduce, I would like you to know that about 25% of our patients that undergo cardiac surgery procedures, they will exhibit some sort of pulmonary dysfunction after bypass and in the post-operative period. 25% is a huge amount, I think. But this 25% will run through the scope from just mild hypoxemia post-bypass to evident ARDS and respiratory failure. Regardless of the specific complications, a PF ratio frequently occurs, a reduction in PF ratio frequently occurs post-bypass. The immediate ABG that we do in the post-bypass period will have some limitation in the oxygenation. So what are the predisposing factors? I think most of them apply to any cardiac surgical patient. Old age, smoking, preoperative lung disease like ARDS or chronic bronchitis, asthma, obesity, cardiogenic pulmonary edema, and impaired kidney function. So in the literature, they define some of the terms of post-operative pulmonary complications, and of course the scope is wide, but because the slide is a little bit tiny, I will tell you that there appears to be some sort of respiratory failure, lung infarctions, pleural effusions, atelectasis, aspiration pneumonia, etc., etc. The list goes on. The mechanism of this dysfunction is multifactorial, of course. You know that the cardiac surgery in itself is injurious, and as soon as the patient undergoes the incision, the surgical incision itself, there is a huge release of pro-inflammatory cytokines from the wound and from the body, and this starts the initiation of an inflammatory process. And then the blood comes in contact with the cardiopulmonary bypass circuit, and this activation of neutrophils and leukocytes and platelets further accentuates this inflammatory reaction. So we have the surgery, we have the cardiopulmonary bypass circuit. After that, we cross-clamp and we go on full bypass. We deplete the lungs from the blood supply. The lung has its blood supply predominantly from the bronchial circulation only. There is no pulmonary circulation, so this is ischemia of the lung. And after that, when we declamp and we start perfusing the lung again, we have reperfusion injury, and so this is another factor. And frequently, we will need blood transfusion, and we will talk about transfusion-related lung injury afterwards. All these effects will cause an inflammation, a massive inflammation in the body, and a huge oxidative stress, oxygen-free radicals, and when reperfusion occurs, there is damage to the endothelium and lung dysfunction. This will manifest as ventilation-perfusion mismatching, reduced compliance, and pulmonary edema. But there are other several surgical factors that can contribute to pulmonary dysfunction. Not just the inflammation, not just that. We open the chest, we disrupt the integrity of the chest wall. We open the pleural, there is pleural effusions, collection of blood and debris, and so on. We, sometimes the surgeon, for simplicity, he opens the pleural just empirically like that. It's not accidentally done, it's like intentionally done. And then, of course, when the patient recovers, he will recover with a lot amount of pain and will not breathe effectively, will not cough efficiently enough to expand his lungs. So there was a concept that these critical population will need 100% oxygen all through because there is insufficient delivery of oxygen to the myocardium, and so it is better to supply the myocardium with enough oxygen to ensure adequate oxygenation. But of course, hyperoxia nowadays is incriminated almost everywhere. Unless there's a specific indication for 100% FiO2, do not use it. But specifically in the cardiac surgical population, as we have said, it is a pro-inflammatory environment, and so the lungs will not tolerate further inflammation or further injury by hyperoxia. This is a study done by Pizov et al. In 2000, and they compared two groups of cardiac surgical patients. One of them was ventilated with 100% oxygen all through, the other was ventilated with 50% FiO2, and they found that the group that was ventilated with 50% had less amount of pro-inflammatory mediators in the bronchoalveolar lavage fluid. They had less interleukins, tumor necrosis factors, and so on. Whether or not this translates into a more beneficial clinical outcome stays a little bit grayish, but the document is that there is more inflammation when using 100% oxygen. So how can we protect the lungs? We've known that the lungs are subjected to injury during cardiac surgery. We need to protect them. We have several routes to follow in order to protect the lungs. Some of them are within our control as anesthesiologists. Some of them are within the domain of the surgeon. Some of them are within the perfusionist's hands. So what we do as anesthesiologists, we might try some pharmacology. We know that this is an inflammation, so try to suppress the inflammation somehow by some drugs. There is no magical drug that will suppress the inflammation and prevent the injury, but some drugs have been tried and have shown promising results, like prostacyclins. Prostacyclins induce vascular smooth muscle relaxation. They improve the oxygenation of the lungs, blood flow to the lungs. They inhibit platelet aggregation, and they decrease endothelial dysfunction. Phosphodiesterase 3 inhibitors. We all know the milrinone, of course. It's very famous here in Egypt. This group of drugs might exert an anti-inflammatory and antioxidative properties as well. So inhaled nitric oxide, of course, is very famous abroad. Unfortunately, we don't have it here in Egypt. We've only used it once or twice, I think, in one of the hospitals. Inhaled nitric oxide is very beneficial, but we have to make sure that it is not applied immediately after declamping, because it increases the injury of oxygen-free radicals. It reacts with superoxide, and this might damage endothelial cells. So it is not applied immediately post-declamping, but it's beneficial as a preconditioning drug and more later than after that. Aprotinine, of course, you know aprotinine. I think most of you have heard it. Aprotinine is an antiprotease and anti-serine protease, and this drug was initially studied for its anti-inflammatory properties, and then they accidentally discovered that it also possesses some hemostatic functions, and it gained its population, its fame as an anti-bleeding substance rather than an anti-inflammatory drug. Steroids, of course, the debate still goes on and on steroids, whether or not to administer steroids. Some modifications has been done to the cardiopulmonary bypass circuit, and these have shown good results, but because we are anesthesiologists, we are not directly in charge of the perfusion. Just to mention, the perfusion material, the circuit material itself, when biocompatible, when it's heparin coated, it diminishes or it reduces the injury done to the cellular elements of blood, and this reduces the inflammation. We can use ultrafiltration, hemofiltration. Hemofiltration, unfortunately, in Egypt nowadays, due to economic reasons, is very restricted in some hospitals because it costs some money. And then when we use leukocytes filter, it also reduces inflammation because it reduces the load of activated leukocytes which sequester into the tissues. Because surgery, as we've said, contributes to the injury, some can suggest alternative surgical approaches like off-pump, for example. We can eliminate the effects of bypass and use an off-pump procedure. We can avoid opening the pleura when not necessary. We can use minimally invasive procedures to reduce the breaching of the chest mechanics and lung mechanics, and of course to reduce the load of released cytokines and inflammatory processes. So what about the main issue here, which is the mechanical ventilation? How can we manage mechanical ventilation during cardiac surgery? We have more or less 3 periods: the pre-bypass, the during bypass period, and the post-bypass period. What can we do in each of them? Very similar to what Dr. Senturk has just said. When we open the chest and we start doing some maneuvers to the lungs, the surgeon is always there, and he always interferes with what we are doing because he sees what we are doing, obviously, but he doesn't necessarily understand it. So just as they open the sternum, somebody will like comment on the lungs, and he says, the patient has COPD, the lungs are not deflated. Okay, don't worry, it's okay, I've added some PEEP. Yes, nice, just remove it. So they don't want the PEEP. Why don't they want the PEEP? Number one, they are afraid that the lungs are not deflated. This is a predisposing factor that the lungs are already bad. The patient will not recover. And secondly, to serve their best interest, they don't want the lungs to interfere with the surgical field. They want the lungs away from the field. But another factor in our advantage is that they don't comment on the tidal volume. They comment the opposite way. They don't tell us increase the tidal volume. They want us to decrease the tidal volume. They don't want the lungs to encroach upon the field. And so low tidal volume, we already advise low tidal volume. So it's in our benefit. But the PEEP, they don't want it. It's against our benefit. So to see these studies in Anesthesiology 2011, they studied the effect of low tidal volume versus high tidal volume. By low tidal volume, we mean 6 mLs per kg, ideal body weight, and by high, we mean about 10 or more than 10. And they came up with the conclusion that low tidal volume ventilation resulted in lower incidence of mechanical ventilation at 6 hours and the less need for re-intubation after surgery. So low tidal volumes are beneficial to our patient population. So what do we do during cardiopulmonary bypass? We have already gone on to bypass. The convention or the tradition is to stop ventilation altogether. We disconnect the ventilator, we turn off the machine, and we go outside for some coffee. But is this the ideal situation or not? Let's see. So we go on bypass, and our dear anesthesiologist here is doing something fishy. The surgeon tells him, we are on full flow, aren't we? Yes, so why is ventilation still going? Okay, I've heard that continuing ventilation during bypass reduces pulmonary complications. Well, nice, okay. Turn it off, please. So they don't want ventilation on bypass. They don't want us to ventilate the patient. They want the field to be as quiet as possible. So somebody, when we go out, disconnects the lung, turns off the ventilator, and when we go inside again, we find somebody that has messed up all our settings. So why is this? Because they have studied that some sort of ventilation during bypass is beneficial, more or less beneficial. It's better than disconnecting the lungs totally. So which ventilation strategy is the best during bypass? Shall we put the patient on a stationary CPAP? Shall we put him on continued mechanical ventilation, for example? Shall we continue like insufflation, just insufflation with no pressure? Anything else like high frequency ventilation? Anything? What do we do? These meta-analyses compared several strategies, including CPAP, recruitment maneuvers, continuing ventilation with the same tidal volume or with higher frequency, and they found that there was a tendency towards improved oxygenation and a better outcome. But this was not much convincing that there was a specific strategy that should be employed. There is tendency towards improved outcome, but no specific procedure by itself is the best. Another study here by Bibignami et al. In 2016, it was also a review article that gathered like 15 RCTs from literature, and they concluded that when we use either no ventilation, ventilation with low tidal volumes with PEEP, or without CPAP, recruitment maneuvers, high frequency ventilation, it might not be possible to recommend a best strategy. There is also a tendency towards some sort of ventilation, but which is the best strategy, it is not yet clear. We came up bypass, and the surgeon is asking about the blood. Do we have some blood and plasma running or not? No, not yet. The hemoglobin is 12, and we don't have any evident bleeding, so I don't think there is any use for blood or blood transfusion or plasma transfusion now. We don't need any trial, do we? Okay, nice. Just please give some plasma and blood. The surgeons are always pushing us for plasma and blood. And in some situations here, you see that there is almost a routine practice that something has to be running when we are coming off bypass. Either it be platelets, plasma, blood, anything, but something has to be running. Why not crystalloids? I don't know. We have to have something natural of human origin. So what is this TRALI thing? TRALI is transfusion-related acute lung injury, of course, as you know it. It is a well-known condition, and not specifically in cardiac surgery, in any kind of surgery, but in cardiac surgery per se, it is very important because we do need some blood, and we are in a pro-inflammatory environment, as we have said. The incidence is about 2.5. It is an immunological reaction. It causes capillary damage. It takes about 6 hours to manifest. And so when we anesthesiologists do induce or trigger the TRALI effect, we don't see it. It's the poor intensivist who takes on the burden of correcting it. So what we do inside the OR might manifest later on. And of course, the bad thing is that it's associated with high morbidity and mortality. And so if we don't need blood transfusion, please don't. Just to give you an idea about the updates or the guidelines of blood transfusion, according to this recommendation of practice guidelines in the annals of 2011, they recommended that prophylactic use of plasma in cardiac operations in the absence of coagulopathy is not indicated. It is not indicated. It does not reduce blood loss and exposes the patients to unnecessary risks. So the concept of giving plasma just routinely because we have to give something is condemned. And about the transfusion trigger, the transfusion is unlikely to improve oxygen transport when the hemoglobin is greater than 10. And hemoglobin levels below 6 is reasonable, not mandatory, not an indication. It is reasonable to give blood when hemoglobin is less than 6. And patients whose hemoglobin is less than 7, but no high-level evidence supports it's a post-operative. It's reasonable also to give when below 7, but there is no sufficient evidence to support it. So there is a tendency not to give blood unless there is evidence. What kind of evidence are we talking about? Something bad going, like for example, a patient who has a history of stroke, of carotid insufficiency, there is ST segment changes, very old age, increased oxygen debt from sampling of the mixed venous, something like that. But just on the sake of hemoglobin numbers, it is not indication. So all of these debates and things that we have talked about, what can we do? What is in our hands to do? Of course, the best or practical way to deal with such patients is the manipulations in mechanical ventilation. As we've said, the surgery, it's not our domain to take decisions. I cannot force the surgeon to do this or that, to take a minimally invasive approach or the traditional approach. The perfusionist is doing his job. I cannot know exactly what he should and shouldn't do, but what's in our control is the mechanical ventilation. We can manipulate our FiO2s, we can manipulate the tidal volumes, we can give PEEP, we can give recruitment maneuvers, we can do what is best in our knowledge about the mechanical ventilation during bypass. We should reduce our blood transfusion practices, and I think the best thing to do is to communicate between ourselves and the surgeons and to let them know what we are doing, because it's in the patient's best practice that we do some protective ventilation, and this protective ventilation might be misinterpreted or misunderstood by the surgeon. One important thing is to optimize the patient preoperatively. Of course, it's not advisable to take patients into the OR unless they are adequately optimized. I think when I gave this topic about like 10 years ago, I was surprised to see that the evidence is still the same. There is always tendency towards something, but there is no evidence. We need to encourage ourselves and our colleagues to make more research about this area to come up with a global consensus about the best practice for the cardiac surgical patient. Thank you very much.
Thank you, Murat. Again, we welcome questions from the very awake audience. Thank you.
Thank you, Dr. Hossam, for your nice lecture. My question is, what is your transfusion cut value intraoperative for patient undergoing CABG, and postoperative? Can we consider them after correction of the cause of ischemia and repair of the blood vessels? Can we consider them they are not more ischemic?
Sorry, the last thing, can we consider them?
After CABG surgery, yes. Can we and reperfusion, yes. Can we consider them they are not more ischemic and
they are no more ischemic and they are yes. not susceptible to ischemia from anemia?
Now we can transfuse blood with hemoglobin below 7.
Okay. So the first part of the question, what's my own preference or my transfusion practice in CABG surgery? To take the more conservative approach, I usually transfuse below 10. Below 10 is like a source of a debate in our institution. I might tolerate lower hemoglobin levels as long as there is no evidence of ischemia, ongoing acidosis. But this will not be properly understood by everybody, so I prefer not to do it, unless there is somebody who is very understanding in my team. So below 10, I usually do transfuse. If there is a chance that the patient is well hydrated and will diurese it himself, and there will be some sort of hemoconcentration that will go on later, I do not transfuse. I just keep him like that with lower than 10, and then when he gets off some urine, he will hemoconcentrate on himself. If a patient is already hypovolemic a little bit, I will transfuse blood below 10. Above 10, I don't.
Yes.
The second part, after revascularization, do I consider the patient
post-operative time?
Post-operative, after the patient has been revascularized, so he is not anymore ischemic or susceptible to ischemia or anemia. I think I do agree with this statement. If the surgeon has performed a good surgery and the targets are known to be good on the preoperative catheterization, surgery is good, post-operative ECG is fine, everything is okay, cardiac output is fine. I think, again, I would think that he is okay, but I wouldn't want to cause a controversy with me transferring a patient on a hemoglobin of 7 to the ICU. They would immediately transfuse blood in the ICU, even though I believe he is good. And so, more or less, I will be conservative and I will give some blood. if the hemoglobin is 7.
Thank you.
You're welcome.
Questions? Comments? Thank you very much, Professor Hossam. Thank you all for your attendance and concentration on the lecture topics. And tomorrow is another day in this conference. Thank you very much, Professor Ahmed Mukhtar, for being my co-chair. Thank you very much.